Let me talk about AFib. Atrial fib is an abnormal cardiac rhythm that is characterized by a loss of P waves and a rhythm that is irregularly irregular. Not regularly regular like a heart block, irregularly irregular. Why are there no P waves and why is it irregularly irregular, you ask? Well, you need to understand what is happening in the heart. The normal conduction of electricity is generated by the cardiac conduction system. The SA node generates an electrical impulse and it travels down the normal conduction pathway. However, there's backup system after backup system in the heart. Every cardiac cell has the property of automaticity, meaning that it can generate an electrical impulse. In AFib, the atria are going fucking haywire. A whole gaggle of the atrial cardiac cells are generating impulses like it's some gigantic cardiac gangbang party. In reality, what is happening when all of these cardiac cells in the atria are generating electrical impulses is that the atria begin to quiver. The atria are supposed to kick the blood to the ventricles, and when you lose this atrial kick, it's an instant reduction in cardiac output by at least 15%. Blood pools in the quivering and kickless atria, and it can actually begin to coagulate and form clots since it's stagnant and not flowing effectively to the ventricles. Since the atrial cells are just kind of standing around generating impulses and the atria are quivering, you lose P waves. Sometimes the atrial activity looks like a fine fibrillation line, and sometimes it looks pretty flat. It doesn't matter. In AFib, you lose discernible P waves because the atria are firing off loads at a rate of 400 to 600 times a minute. Remember, though, that these atrial cells that are firing can and do generate enough of an impulse to cause a whole-ass heartbeat. And that's why the rhythm is irregularly irregular. There's no rhyme or reason to when one of the 400 to 600 atrial beats per minute are going to fire off a load that is going to generate a heartbeat. Sometimes it happens at a normal rate. Sometimes it happens at a really, really fast rate. And just because someone is going to ask the question, there's always one in every crowd. Yes, you can get bradycardic AFib, but it is much, much less common. Usually due to the decay of the cardiac conduction system due to old age and or heart disease, or it can be due to an overdose like a calcium channel blocker or a beta blocker. Don't get too wrapped up in it though. AFib is often chronic. Some people are usually in it. Some people are always in it. In EMS, we mostly worry about paroxysms of rapid atrial fibrillation. Here are symptoms of atrial fib. You can read them for yourself. What causes these paroxysms of atrial fibrillation with rapid ventricular response, you ask? Well, it can be anything from simple sympathetic stimulation to more complex stuff that's not well understood. Interestingly enough, myocardial stretch, like that happens in heart failure, can activate AFib, and that's often why AFib and CHF exacerbations go hand in hand. When the AFib is rapid, not only is the heart getting exhausted from firing at a fast rate, but the heart isn't getting time between beats to adequately fill with blood. Combine that with the loss of atrial kick, and the patient will suffer a severe loss of cardiac output, and the heart will not be effectively pumping blood to the rest of the body. So you have to treat the rapid AFib when the patient is symptomatic. When the patient is symptomatic. We don't just treat AFib because it's there. Personally, if the patient is rock stable, not really symptomatic, and the rate is under 150, I just throw in a lock of life and monitor and transport. But if they are symptomatic, you need to treat it. And the goal of treating the patient is not to convert the rhythm. Leave that to the cardiologists in the EP lab. If you end up converting the rhythm, whatever, that's fine. But we are simply worried about rate control. We want to slow the rapid AFib's ventricular response so the heart can fill with blood and pump effectively. If they are unstable, you cardiovert them. Simply put, I think we all know this from school and from that watered down travesty called ACLS that we are all forced to take at gunpoint by that criminal organization known as the American Heart Association. If they are not unstable, you can use meds to control the rate. The standard for EMS is using a calcium channel blocker, most commonly cardizem. However, some emergency medicine physicians, particularly medical command physicians in Pennsylvania, for some weird reason, are paranoid about us giving cardizem because that drug also vasodilates and they are worried about us dropping the patient's blood pressure. Yes, this certainly can happen, no doubt about it, but I and the cardiologists say that we give cardizem for rapid AFib to allow the heart to fill with blood and perfuse the body better. That's the whole fucking point of why they chose cardizem to give to rapid AFib. You'll actually improve the blood pressure by slowing the rate. But I digress. Calcium channel blockers are a mainstay in the first-line treatment of AFib with RVR. You can use beta blockers as well first line. Statistically, they work just as well. They work differently from calcium channel blockers as they decrease sympathetic tone and slow nodal conduction, while calcium channel blockers work specifically on, well, calcium channels. Amiodarone works for refractory AFib, less commonly known and used in the emergency medicine setting, but magnesium sulfate is an extremely effective adjunct for controlling the rate. That being said, take note that I said the word adjunct. It has not been shown to be overly effective by itself or as a first-line med to control AFib. The question that often gets asked is, if we convert the AFib without the patient being anticoagulated first, are we going to cause the patient to have a stroke? Remember, blood is pooling and is at risk for coagulating in those quivering atria. Yes, that is a real concern. However, it is a real concern in the person who is in chronic or permanent AFib. If the patient is going in for an ablation or a scheduled cardioversion, then that is a big deal, and you definitely got to anticoagulate them first. The risk of causing a stroke or other embolic event when treating an emergent, rapid, symptomatic, paroxysmal AFib with rapid ventricular response is actually extremely low, and a risk-benefit analysis says to please treat the symptomatic, unstable, or unstable-ish patient who is in rapid AFib. If they present with chest pain, shortness of breath, hypotension, or whatever that makes them sick, and they are in an AFib at a rate of 220, please, please, please do not be the cuck in the corner who does nothing because they are scared of causing a clot to be thrown. You don't want to deliver a dying patient who has zero blood pressure and froth coming out of their nose to the ER and saying, I didn't treat it because I was worried about clots.